It's a privilege to be a part of this morning's discussion and to help lead the next part where we focus on some market research so that I can give you a little bit of information on how people with diabetes and the public have responded to the issues that you face at states related to making decisions about diabetes-based legislation, and then give you a couple of ideas about audiences that might be something to consider as you think through what your next steps are after hearing all of that valuable information earlier. So again, my name's Nicole Johnson. Most notably, this month I started 20 years, or my 20th year, with type 1 diabetes. So I stand here before you as a patient, as an advocate for people with diabetes, and as a scientist. I do research on social behavioral issues related to people living with diabetes and chronic diseases. So that's very much focusing on psychology, on family dynamics, on how we intersect culture and our reality of our life situations with the scourge of diabetes and what that means to people's lives. So I've been very blessed to have multiple honors and awards throughout the years related to diabetes. It all started, though, in 1999 when I was named Miss America. And what an exceptional opportunity that was in and of itself, but to be named Miss America with diabetes was a very unique position and something that that organization and our nation had never seen before. So I was given the opportunity to travel all across this country and then subsequently all over the world, teaching people about what it's like for individuals to live with this disease. In the subsequent years, I've been blessed to pursue lots of education, and as you can see, I'm almost done with my last step, and that's my Doctor of Public Health degree. So soon that will finish up. But back to that 20 years. When I was diagnosed in 1993, there was little emphasis on the things that we've been talking about this morning. There was little emphasis on the importance of intensive management of diabetes. There was little recognition of the different circumstances that face people with diabetes throughout the life course of living with a disease. And in fact, during my diagnosis experience, I was actually informed that my life expectancy would be remarkably shorter than my friends and colleagues at the time, and therefore didn't need to worry about too much. And undoubtedly, success was not an option for me. Thankfully, opinions, attitudes, and science have changed. So today, what I want to focus on are a couple of these interesting issues that we have been already highlighting this morning. The threat that diabetes poses to the various cultures and segments of audiences that are... We're causing the lights to flicker. That's There's a vibrance in the room. But then we're also going to talk about the unique challenges that diabetes poses to specific populations, women and children in particular, and then identify some potential solutions that might be useful to you in your environments. The sobering reality is what you have heard already, and really what I'm here to do is, as a person, as a human, in the experience of diabetes, is to plead for your help. As a public health professional, I'm here to tell you that we are looking for partners and collaborations, and there is not enough support for prevention activities, and then there is certainly a dearth of creative implementation. So the time is now to make some remarkable and notable steps to move forward. So I'm sure that you have seen these maps and these graphs in the past. It shows you how the prevalence has been shifting and changing over the course of the years. And, it's fascinating to think back just on my experience of diagnosis in '93 and then '99 when I was named Miss America. At that time, diabetes really was not taken seriously. We knew that it was a problem. We knew that it was economically a challenge, but it wasn't impacting us to the degree that it is now. There were only single-digit percentages of the American public that even viewed diabetes as a serious issue at that time. The diabetes community itself was and still tends to be torn about how to best illustrate the severity of this disease because of a couple of factors. Number one, they don't want to scare people. And number two, when it relates to families, families and parents in particular are fearful of sharing the severity information related to diabetes with their children for the fear of scaring them and thwarting their ideas and dream-making behaviors. So if we fast forward to now, in 2012, diabetes has exploded, as we've already talked about. And it not only threatens to damage our society and the lives of the people that are connected to the disease, both those that live with the disease and the families that surround them, but also our financial stability of the healthcare system. Yet, despite that, a much more aggressive stance by the diabetes community and policymakers, and for a few die-hard, incredible volunteers and leaders, we still have a hard time persuading federal and state leaders to make diabetes a priority. This is still, in short, not taken as seriously as it should be. So the perception in the public, however, is lagging behind that. And I want to give you some market research that was recently done through the means of a survey for Novo Nordisk, and it shows that Americans see diabetes as a growing issue. And in that survey, it was noted that 52% of Americans are extremely or very concerned about diabetes. I hope that you are in that 52% and move that number upward, especially because of the esteemed positions that you hold. So last year, multiple organizations and public health authorities, the CDC, the World Health Organization, the International Diabetes Federation, and others, all issued new diabetes prevalence numbers. And they continue to move upward at a rate that is astonishing, a rate that we can't keep up with, and that most folks don't know what to do about. Although each of the numbers from each organization were a little bit different, and we heard this morning, they all said the same thing. The time to act is now, before we're crippled even more by this condition. So in fact, that study that I just mentioned, the market research with Novo Nordisk, they commissioned then with the Institute for Alternative Futures projects that diabetes in the United States will grow from today's nearly 27 million people to over 50 million people with the disease over the next 15 years. The direct and the indirect costs associated with that as you build your cases to take home of why it's important to consider this issue is that cost will be $500 billion annually. That's $500 billion a year. With a disease that is largely preventable in many ways, that we can avoid complications, and we do have good, solid science that we can apply if given the chance. But you don't have to just take my word for it or that market research. Consider a little bit of what our government agencies with the CDC have said and taken to heart. 2 weeks ago, so this is the most recent information that we can provide, the CDC said that diabetes increased over 100% in more than 18 states over the past 16 years. And that's a little bit what we were talking about this morning. So looking forward, though, the estimates are sobering. So the estimates project that the incidence of type 2 diabetes will quadruple from where we are now. The incidence of type 1 diabetes will triple, all by 2050. So that just paints an even more vivid picture of the reality. So it's kind of like a wake-up alarm, isn't it? At least I hope so. Again, let me underscore that as a woman with diabetes, I am desperate for you to take action and to think creatively. As a public health professional, I am eagerly looking for collaborative environments to be able to implement strategies that are proven and evidence-based that will make a difference in people's lives. We can change the course of population behaviors. So unfortunately, diabetes disproportionately affects so many populations, and this also was referenced earlier, but here are some statistics in writing that you can use to build your cases of the percentages of the populations that are impacted right now. However, the forward-looking picture is much more powerful. So as we look forward into the predictions of the trouble that is facing us, we should look back on some of the successes that have happened over the course of the last several years. There have been a number of important diabetes policy milestones on the federal level, and let me remind you of those. Medicare coverage for diabetes testing supplies and equipment was a landmark. Self-management training and the coverage of that for people who live with diabetes, invaluable. Nutrition counseling and food behaviors tend to be the most challenging aspect of living with this condition. The Special Diabetes Program, which is significant research investment in type 1 diabetes and Native American diabetes research. And then Medicare Part D for medication. And in that bill, CMS also authorized for the first time the ability to test for diabetes among seniors who had risk factors but yet no symptoms. All of these laws are a great boon for people who live with diabetes, and they aid in that ultimate prevention. We need to move the ball forward, though. There is still so much that can be done on this state level, and it's evidenced by the fact that we continue to lose ground with this diabetes epidemic. The problem is just getting worse. So where are the creative interventions? The things that will address the burden. We must think about how states can engage in new ways to ultimately benefit communities. So the health trends that predict the serious trouble that we're facing are noted here. And this is the NCQA data. It finds that for people with diabetes over the last 5 years, that there has been no significant change in the number of those achieving good control. There are fewer are receiving the screenings for the complications related to diabetes and that are so connected through the micro and macrovascular systems. There are no improvements in eye exams to prevent blindness. All of these things we can make incredible strides toward, and we can improve quality of life for millions of Americans if only we would implement the standards that we know about and that we have evidence for. The big problem? NCQA does not measure for simple blood screening utilization to measure for gestational diabetes. This is one of those creative interventions. It's an idea for you to consider as you think about what is your role in this issue. So let's talk about gestational diabetes and the unique position that women are in as they live with this healthcare condition. Now, there is not good data about the percentages of how many men versus how many women live with diabetes. What we've found generally is that it's about equal. In the Latino and the African American populations, though, we must consider gestational diabetes as a serious, serious issue for concern. There are different cultural behaviors that lead to considering this. Traditionally, Latina women become pregnant at earlier ages. This offers opportunity for us to impact the lion's share of their lifespan and the risk that they might be facing because of diabetes. So women have special challenges. We need more specialist types of legislation that approach some of those challenges. And if we just think about the scenario of women, adult women who live with diabetes, they are balancing so many different elements from work to caregiving, and where does prevention fit in? And how are we emphasizing prevention and those types of behaviors to these women and communicating with them in effective ways about the reason to utilize prevention. So this slide shows you some of the percentages and things that are related to the unique position that women have as they live with a chronic condition. On the left-hand side here, you see women ages 18 to 64 with public insurance. The blue indicates women with diagnosed diabetes. The red, or the purple, indicates men with diagnosed diabetes. That in and of itself speaks volumes to where some of our financial and cost savings could be. On the right-hand side, you see a graph that says women ages 18 to 64 who rely on public transportation. Again, the blue indicates women with diagnosed diabetes. The purple represents men with diagnosed diabetes. Just think if we layered on top of that men and women who live with prediabetes or have at-risk who are at risk for diagnosis. The opportunity for new engagement exists here. It's an opportunity for you to engage maternal child health professionals, new health professionals in the scope of clinical care, obstetricians, gynecologists, and primary care in a new way. We must also remember that message points or legislation or different initiatives that target women then have a trickle-down effect because women are the primary caregivers and the primary deliverers of health information to the family unit. And that is not only to their spouses and their children, but also to their parents and other secondary affected family members. So gestational diabetes in women. Let's give you just a couple of pieces of information. This is unique to women, and when undiagnosed, it threatens the health of the woman and the child, both the unborn child and when the child is born. According to the CDC, up to 18% of pregnancies, 1 in 5 pregnancies, are affected by gestational diabetes. And now there's some fiddling with the percentages and the numbers because there's not very good understanding around how big of a problem this is. I would venture to say this is an underestimate, although I've given you the top estimate number that's available through the CDC. But when we think about the prevalence and what you learned earlier this morning, and the fact that from the year 2000 onward, 1 in 3 in our population will have diabetes, and 1 in 2 in communities of color will have diabetes, that number is much greater, especially when we also consider on top of that the cultural issues. So women who have had gestational diabetes have a 35 to 60% chance of developing type 2 diabetes in their lifetime. That usually happens within a short period of time after delivery of that baby. What this says to me is this is the prime time period to reach a specific population with targeted interventions, programs, services, education, so all that collaboration that we need to do to be able to thwart an ultimate diagnosis of type 2 diabetes. Now, mind you, gestational diabetes, it happens and it's not really understood completely, as we had the discussion about genetics, about environment, about lifestyle. This is not fully understood. But if you consider the same type of positions around type 2 diabetes and the behaviors that seem to lead to that type of diagnosis, compare that to the gestational time period. If women in pregnancy gain a large amount of weight, it puts them at more risk for this condition. But there are also unknown factors, and environment tends to play a big role. That's why I mentioned Latinas earlier. But then let's think about those children as well. If mom has gestational diabetes during pregnancy, the child is more likely to struggle with obesity throughout youth and into adulthood, and they are more likely to be diagnosed with type 2 diabetes. This, again, is a great prevention strategy and something that is not being done, and there has never been proven. There is not a track record for addressing this issue. So why should you care? Why is this important? Well, it goes back to that graph that I shared a few minutes ago about insurance and the number of women utilizing public insurance. And it also goes to some of the challenges that women face with their lifestyles. Employment challenges, the flexibility in work schedule challenges, transportation challenges, and let us not forget caregiving issues. So gestational diabetes screening again is not happening, and it will not happen unless it is mandated. So unless you do something about it. When gestational diabetes is present, the costs of care to both the mother and the child rise dramatically. So who will step up for these vulnerable populations? I hope that that's you. And again, that's the desperation from a human element talking, as well as the public health background. I am a mother of a small child. I went through pregnancy with type 1 diabetes, slightly different, but yet same set of circumstances. My child, because I have type 1 diabetes, is at a greater risk for challenges with obesity and potentially type 2 diabetes in her lifetime because of the challenges that I faced during pregnancy. This is such an opportunity for so many elements of that caregiving scenario. So the bottom line, and I think I probably have already hit this, but that we must require state health insurance programs, Medicaid programs, to track screenings for gestational diabetes. This gives us information on those who are most vulnerable to a diagnosis of type 2 diabetes. It gives us a population set to utilize for interventions. And it's a place where it's honestly low-hanging fruit, where we can make a tremendous difference in a very short period of time with some common sense programs. We must require Medicaid health plans to provide information to women with gestational diabetes on how to manage that condition effectively. Right now, the information they provide is inadequate at best. And we need to track the health of the mother and the child when gestational diabetes is part of the picture. This offers us, again, a wealth of information to then be able to better serve our populations and communities. These solutions cost very little, but they will save us an incredible amount. But let's also talk about these children that are impacted by diabetes. They are another vulnerable population that must be considered. I was diagnosed with diabetes as a teenager. And when I was diagnosed, it wasn't good news. I told you that I was informed that my life potential was not good, that I did not have a lot of promise in terms of having a professional career. I was also told that I'd never become a mother. Now, all of that information was false and all of it was wrong. What that spells to me, again, is more opportunity. We can create better, more creative strategies that address some of the prevalence and incidence problems, that address prevention of the complications, and that also recognize the psychological and psychosocial needs of this population. That is something that is yet also untouched. So with children, if the current trends continue, and I've already said this, 1 in 2 minority children born today will have diabetes. This is what we're facing. The epidemiology of this condition in America has been changing over the years, and I have to, in good conscience, provide you at least 1 or 2 science slides. This shows you the trends of the increasing prevalence. And it shows you varying populations from youth to older adults to middle age, and you see everybody across the board is moving upward. This trend has huge implications for the healthcare system, for our cost, and for our long-term consequences. This is the growing problem of diabetes in children that was brought up a few moments ago, talking about interventions and programs that might be able to service the youngest victims of this condition. You see both type 1 and type 2 diabetes noted here. The remarkable trend and change over the last decade has been with the type 2 diagnosis in young people. Again, we've recognized the issue. We need to move to implementation planning and implementation in communities to stop these trends. The federal government has proven here that they will not rescue this situation. So it is up to the states. But I have to ask, if we are focusing on spending money on prevention, what are we preventing? We must be specific with our strategies. We need to not have generic messaging, but rather messaging that makes sense to people in their reality and what they're facing. It's that old adage of what's in it for me. So we must engage social marketing professionals to intervene here. Now, it's no easy task, and preventing diabetes is going to take a combination of personal responsibility, the private sector's investment, and a big commitment from our states and ultimately the federal government as well. It's also going to take messages that make sense, and this slide is one of those messages that makes sense to us. I'm not saying this makes sense to the general public, but it does show that diabetes has the largest % increase in cause of death, and that's notable. Now there it is. And this is a funding slide that shows you why the time is now to act. So how do we move forward? And here are some additional implementation and strategies for you to consider that might be beneficial in your states. Enacting targeted legislation that holistically addresses your state's diabetes pitfalls specific to your concerns. Convening bipartisan diabetes caucuses. One that's a good model to reference is North Carolina. Establishing a state diabetes legislative task force. Utilizing WIG and other member association tools to host in-state briefings. Those promote collaboration and the breaking down of silos, and then public-private partnerships. That's how we pay for some of this, and that's how we drive that social marketing to be able to reach people. So there are a couple of targeted pieces of information, and I'm not going to go in depth because you heard about the Diabetes Action Plan earlier this morning, but I will say that this is incredibly beneficial, and it's a driver of gathering information and being able to track how are we doing with the prevention and with the actions to detect and treat diabetes, what's being done so that you have real information, and then holding people accountable. It also requires a refreshing of this information every 2 years so that you are current and your state does not lag behind. One thing that we did not go into in depth, but will in a few moments, is Safe at Schools legislation for those interested in youth with diabetes, providing safe environments for those young people to function with their disease, and also helping to address some of the challenges that we have with workforce and nurses in schools. What we have done is a stopgap. We'd love to have nurses in every school, but that's just not our reality right now. So this Safe at Schools legislation, which has been passed in numerous states, you have the Georgia model in your packet. It gives you a creative option for taking care of young people who specifically live with type 1 diabetes are in the school setting, providing them with the maximum benefits of education instead of taking that away. But another best practice for you to consider are these public-private partnerships and collaborations. And I must tell you that Kentucky is a good example. They recently convened a meeting to discuss steps that the state could take to combat diabetes. They've done it in various venues, but most recently it was with decision makers. And the Secretary of the Cabinet for the Health and Family Services in Kentucky, who after the meeting, in breaking down those silos, noted that she was committed to moving forward and seeing She pledged her support to combat this disease. She sees the YMCA diabetes prevention program as an important tool, as well as a host of other options. So these are ideas for you, and the vulnerable populations are other ideas for you to consider as you move forward and make your decisions about how you might be able to affect the trends in diabetes.